Welcome to the Pro Aging Podcast. I'm Steve Gurney, founder of the Positive Aging Community. We're excited that you can join us for our interactive discussions with pioneers and thought leaders on a wide variety of topics related to aging and longevity. We're able to bring these discussions to you along with copies of the Positive Aging Sourcebook thanks to the support of our Positive Aging Community champions. Visit proaging.com to connect with them and find hundreds of other resources. Today we had a discussion with two of my favorite people. This is part of the Living Your Best Life series presented by CarePatrol. We talked with the co-authors of Brain Health as You Age, a practical guide to maintenance and prevention. So let's jump into an informative discussion with Dr. Steve Simmons and Jodi Lyons. And then I'm going to let our folks in from YouTube and LinkedIn. Okay, so all right. Well, this is a special treat, folks, because we've got two of the co-authors of Brain Health as You Age, Dr. Steve Simmons and Jodi Lyons, and let's welcome them to the stage and kick off what I know is going to be an amazing discussion, because we already got questions coming in. Hey, Jodi and Dr. Simmons, real excited to have you all here. And we're going to dive into the book and Brain Health as You Age and some tips and things of that nature. But before we do, especially for those that may not know the two of you, let's get to know you a little bit better. And I'm going to do the traditional ladies go first. So Jodi, if you want to give a bit of your background, and then we'll meet Dr. Simmons, and then we'll dive in. And I also, we've got some folks that are using the Q&A. These are interactive discussions, folks. So if you have any questions, type them in either chat or Q&A, or raise your little virtual hand, and we'll open up your mic, and we will kick this off. So Jodi, tell us a little bit about yourself.
Great. Well, great to see you, and thanks for having us here. I'm really excited. And Dr. Simmons, good to see you virtually. COVID has been quite interesting with who we don't get to see in person these days. So glad everybody's here. Brain Health as You Age came out of a request from our literary agent who said, "Hey, do you feel like writing a book on brain health?" And I said, "Yeah, sure." Before we had written that book, I had run medical societies for probably 15 years. The last one was an association of long-term care providers with assisted living, nursing homes, home health care agencies, etc. And I ended up transferring from that association to doing international case management, helping people find the care they need throughout the country. As of now, born through COVID, where we couldn't go in and do hands-on for most of my clients, I am now with a company called CareBrains. You can check us out at CareBrains.com. We do education and training and national placement for people, including legal, financial, and all of that paperwork. And I do have one more book in the works. It's at the publisher now. And one of the things I find quite interesting is during COVID, when they took all the national emergency supplies for the COVID emergency, the paper that was supposed to be used for books got turned into masks. So my book is now delayed until November instead of coming out in February. And that book is a fictionalized version of Lewy body dementia. But I'm thrilled to be here today with Dr. Simmons to talk about Brain Health as You Age. And we really do hope, I know I'm speaking for both of us, we really do hope to have lots of questions. We don't need to speak to ourselves all the time.
I love it.
Great.
And Dr. Simmons, I've known both of you for a long time, but I always love hearing about both of your career journeys because they're so interesting. Dr. Simmons, tell us a little bit about yourself.
Be glad to. I'm an internal medicine doctor. I completed my medical school in Tennessee. I did my training in Denver, and I've been in the Washington, D.C. area since 1998. a bit of a restless career. I spent a decade in Kaiser's urgent care department. Then I worked where I actually met Steve the first time with a house call practice. The house call was my thing, and that was based out of Vienna, Virginia. Currently, I work for MedStar. I'm in their geriatrics department in Montgomery County, and I'm working at a specific rehab nursing home center called Brook Grove Rehab, and that is in Olney, Maryland. So that has been a very interesting career path for me. While I was doing and seeing patients in the home, it was such an interesting opportunity for me to learn what it means to try to age in place, to try to help support our elderly patients. And this is, I think, in large part how I ended up in a geriatrics department. I found it fascinating. I think this is worth mentioning today. We have a problem of what to do, and how to optimize the care for our elderly patients, and especially dementia, because of the success of society. If you look at the turn of the 20th century, the technology of the 20th century resulted in a prolonged life expectancy. Our science became better, our medicine became better, and as people began to live longer, their problems became more complicated, and our obligation to treat whole people, not just their problems, became a much harder transition. I would say that working in nursing homes now, I'd read recently that there's 1.5 million nursing home beds in this country, but by the year 2040, we will need 5 million nursing home beds. The interesting epidemiology point of view would be that ever since we became as successful as we are in treating these chronic medical problems, we've entered a new epidemiologic phase at the end of the 20th century, which is in a geriatrics textbook I really like, they describe it as the postponement of death from degenerative disease. And in that, dementia and Alzheimer's really takes the lion's share. Neurologic diseases are the main reason people lose independence. Musculoskeletal diseases, which really includes a lot. That's the second most common. And the third is loss of sensory inputs, blindness, hearing impairment. But just to get back to Alzheimer's and then try to close my remarks would be just some numbers. In 1980, there were 2 million people older than 85 with Alzheimer's. That number at 2000 was 4 million. And by 2050, it's estimated to be as high as 10 million. So we're going to need more nursing home beds. Our success technologically becomes our challenge ethically in how we find the optimization for all of our seniors, all of my patients, and whether that's in the home or now in rehab or nursing and assisted living. I know I've practiced medicine in all of these places. It's a challenge for us to get it right. And the last comment I would make is having helped my own parents through this to the end of their life, having seen my own mother for the last time through a window in a nursing home, I'm aware of these challenges. And all children, all spouses are trying to get it perfect when they're trying to make decisions for their loved ones. So that becomes our job. How do we help them run it perfectly or as perfectly as possible? So I hope we get some really good questions. I hope they're challenging, and I hope we can help our audience to learn more about how to get it perfect.
And I see them coming in. I see some hands raised. For those that raise your little hand, just make sure that wasn't a mistake, and we'll get to you. But one thing that I want to do, well, first off, we're going to take a glimpse at the table of contents of your book, Brain Health.
Perfect. Thanks.
But this is an interesting because it's three of you wrote this together, Dr.
Yes.
Simmons, Dr. Mansbach, and Jodi. And but I'd love to know a little bit about how that came together. But if we take a glimpse at the table of contents too, this may sort of trigger some comments on sort of how you all put this book together, and what are some of the key elements that people need to know that are being discussed in the book.
Jodi,
Well, I guess
you go.
I'm sorry, what'd you say, Steve?
Go ahead, Jodi. I was going to bow out to you. I should have been quiet.
There you go. Saw the water being raised there. So I had written a previous book on case management, and I had a literary agent, and she called one day and said, there's a publisher who's very interested in a book on brain health. Do you feel like writing one? And I said, well, sure. I mean, 99% of my clients have some form of dementia. I was on the board of the Alzheimer's Association National Capital Area at the time. But I also spent probably 80% of my working time working with Dr. Simmons as we were seeing patients in the house. And I said to him, I'm not writing this without you. And he very graciously agreed. Very, very helpful. And then we both contacted Dr. Mansbach, who has some incredible research on brain health, and he's got scientifically validated tools. And so the three of us put together the formal book proposal that you have to send to the agents and publishers, did all of that. The little known fact of this book, and you can see when you look at the end chapters at the table of contents, is within a week of our submitting this book proposal to the agent, I ended up in the hospital. And I ended up in the hospital needing a triple bypass and having a stroke. Yet I would like to say that with two doctors as the co-authors, we still hit our deadline. And one of the things we've looked at is, and that's because the two of them are phenomenal, and because we have technology that was literally my right hand. But one of the things you'll notice throughout the book is that it's not that each of us wrote a chapter. We all wrote all of the chapters together. We all edited each other's work together. So as I say, a medical anthology is a layer cake. We wrote a marble cake. So you'll notice within each of the chapters that sometimes there's a little bit of debate, and you can tell that the three of us were debating and coming at it from slightly different angles.
I love it. Yeah. Why do we care about brain health? What is the brain? How does it work? The aging brain, what's normal, what's not? Warning sign that something is not right. Delirium, sudden confusion, defining the dementing diseases, other insults to the brain, lowering your risk of cognitive decline, cognitive exercises, managing expectations, sexuality in normal America, aging and dementia, practical advice for people with dementia, advice in the case of stroke or other sudden onset cognitive problems, caregiver survival guide, 20 helpful tips, and tales from the other side of the bed. And I'm reading those chapters to you because I realize some of you may be listening. Also, it may be hard to read those chapters on the screen, but I'm reading those because if you're in the audience right now and any of those chapters sort of triggered a question or a comment that you might have, let's let them rip. And awesome. So we've got some questions here. And so why don't we just jump in? And I think this will sort of help with the dialogue. A friend of both of yours, Angela Baker, she says hi, and she says, she says, I have a good friend in her 50s who recently had a severe stroke and has not recovered much movement at all. What is the best current resource you're aware of for stroke recovery? And then I believe actually chapter 14 in your book, maybe talk a little bit about the correlation of stroke and dementia.
Dr. Simmons, why don't you take that one after I make one comment?
Sure.
And I will tell you, my comment was, I had the stroke in my 50s, and you're looking right now on the screen at one of the reasons I recovered. Having a phenomenal medical team there as your friends, as your psychological crutches, as helping you with everything, is how I survived, which is you got to have the right team around you. So now I'll toss it to you, Dr. Simmons, for the scientific answer as opposed to the Jodi personal answer.
It's for me, when I am asked about a stroke recovery, and this is a question I am getting a lot here in a rehab setting. You know, I've seen quite a few strokes in different parts of the brain. One of the things that I've learned to explain to my families and my patients is the way that I look at it. And if you're training now as a medical provider, a doctor, a nurse practitioner, you're most likely going to learn that there's one of two choices with an injury. It's either a TIA or it's a stroke. It's either something that comes transiently, leaves without impact, or it's something that leaves its footprints. And while that is, I understand the accuracy of it, I think it misses the point and it squeezes the hope out of the equation. I'm now old enough to be able to say, that's not how they taught me. When I was in medical school, and this was in the late 80s, early 90s, we were taught there were three categories. And in the middle of TIA and stroke means permanence, there was something called, and it had four letters in the acronym, and it was RIND, and it stood for reversible ischemic neurologic deficit. So just hear the word reversible, please. And the point is that you really didn't know what was permanent till it had been a year. And you only made the stroke definition after a year. Now that was glossed over in my medical school days. It was taught, and then it didn't really continue forward, but I always remembered it. So I always tell my patients now in rehab and in the home before or in assisted living, you know, you've really got to optimize everything now that you've had a neurologic event. You need to get it perfect. I need to get it perfect. I've got to get the blood pressure managed. We got to get the medicines right. Some people need to have a SSRI to optimize recovery. And I'll also explain the difference. I'll explain what neuroplasticity is. And if your nerve cells die, they're dead. But most people don't realize, they just think the brain is a set of circuits that are all neurons. But for every nerve cell whose job it is to transmit a signal, there's multiple supportive cells, like the workers, the infrastructure of the brain. And neuroplasticity means that infrastructure is reconnecting around dead zones, would be a real oversimplified way to put it. So I tell people, you either use it or you lose it. You maximize everything, you push it, you do everything you can, and you keep optimistic. And you realize that for up to a year, you can see recovery. Sometimes it's through regrowth, but usually it's neuroplasticity and regrowing connections. I try to be optimistic. And in understanding that there's a reversibility to the defect, there's also hope. That's how I approach stroke care now, and it always has been.
That's great. And Angela, so, and again, this is recorded, so, you know, maybe share Dr. Simmons' remarks, but I'm also dropping in a nonprofit resource in the area called the Stroke Comeback Center that is really an amazing resource for families and individuals that are going through stroke. So hopefully that's helpful. Now, what's the correlation between, you know, again, referencing your book in chapter 14, the reference between stroke and dementia and memory care? I know sometimes stroke ties in with aphasia, and sometimes people get confused that aphasia might be dementia because of people's delayed thoughts.
Yes. For me, when you talk about dementia, it's to me, I always remind myself it's now more of a legal definition than a medical. If you really answer in a medical test, you better call it major neurocognitive disorder. But dementia does mean that through mental or neurologic diseases, you're unable to live in independence, would be a real simplified way to put it. Now, under that category, Alzheimer's has the lion's share of it. It's 60%. If you're looking though at vascular dementia, which is either a whole lot of little strokes or a real big one once, any of it fits. That's about 20% of your dementia cases all cause. So strokes can lead to dementia. If you lose enough brain, you can end up being demented. You can't live in independence, and then we see other things. The fascinating aspect of the difference is Alzheimer's, if you get the right far enough view back over time, you'll realize that it's more of a linear regression, whereas strokes is a step function. The person plateaus for a while, they're the same, then all of a sudden they're different. It's through repetitive strokes. And again, to reference my youth, we were taught it's multi-infarct dementia, like a bunch of strokes and now you can't use your brain right. So there is a correlation for sure. Now, to touch upon the aphasia, I think it's worth mentioning that. If you're understanding the words I'm saying, whether you're interested or bored, either way, you do not have a receptive aphasia. You can receive the words and process them. A person who cannot has instant dementia. If you don't understand what's being, that's it. But there's lots of people who can't get the right words out. That's expressive aphasia, and it is not a dementing illness. If a person says the wrong word and shakes their head in frustration, they just disproved dementia. Mm-hmm. They heard the wrong words. Wow. So aphasia can occur after a stroke if it hits the right speech centers. It's the frontal temporal lobes. There's a Broca's and Wernicke's center. Depending on which one gets hit, you end up with either expressive or receptive. If you get them both, that's really terrible. And then one last generalization is, I'm right-handed, most of you are. 95% of us that are right-handed have our speech centers on the left. If you're left-handed, it's a coin toss, 50-50, whether your speech centers are right or left. So for the right hand, you get a left-sided stroke, you're most likely going to have speech affected. Left-handed, it's a coin toss, depending on which side of your brain it hits.
Excellent. All right, we got a pile of questions.
Keep going.
A couple are just clarifications. Arlene wanted to know, what is SSRI?
Oh,
yeah.
All right. Prozac is an example. Now, it stands for selective serotonin reuptake inhibitor. So it makes the serotonin sit in the neural synapse longer to do its job, basically. Let's contrast that. I'll ask a question, answer it. What's an SNRI? Selective norepinephrine reuptake inhibitor. So the RI will always be reuptake inhibitor. It inhibits the uptake of some neurotransmitter in order to increase signal across from nerve to nerve, the nerves you want. And it's typically another way of saying, we're giving you an antidepressant that was invented after the 60s and 70s.
Great. Okay. And I found a definition. I'm dropping it in there, Arlene. Hopefully that's helpful. And then I'm not sure which one of you had that the quote, squeezing all the hope out of the equation. Somebody asked.
I think that was me. I think I said that a minute ago.
Okay.
Yeah.
And they said, could you repeat it, please? And what was this quote in reference to?
Oh, no. See, I get into this kind of trouble all the time at home. My daughter will say that again. I'll say, I'm sorry, I was in the moment. I can't. I'm going to say that to you. I was in the moment. I can't. But I'm not quoting anyone but myself. I'm trying to instill hope and to never snuff it out on all of my patients. And I find that if you give a person a carrot correctly, you don't need the stick, especially in rehab. And so I find that the current definition that you either have had something reversible or it's permanent, I believe it squeezes the hope out of the situation of having had a stroke. I like to tell people, look, there is hope. You can recover for up to a year. I love to do that. I love to help encourage people to try to do better. And I find that I get really good results if I can get a person motivated.
Wow.
Okay, and I see showing up in the chat that they were saying that you were talking about back in the day that strokes were permanent. For clarification, there are multiple kinds of strokes. Some strokes were considered reversible, like a TIA, transient. Some are permanent and there's permanent damage. But the question is whether your neurons can grow around the damaged part to then give you functionality back. So I think the confusion is coming. It's not just death of the neurons. It's what happens because a neuron died, right? You can't move your arm, you can't speak, you can't whatever. How does your brain recover to allow you to regain some of that functionality? And so what Dr. Simmons was saying is he gives people hope. He says you have up to a year, and let's be honest, sometimes even longer than that, to see what the real damage is. So as he would say to me, take a deep breath and let's go.
I love it. Okay. Let's see. Latte asks, how can one treat delirium as a caregiver? Again, I'm glad I read the chapters of your book, because I think one of the chapters dealt with delirium. But first, for those of us, what is delirium? And then how can we treat it? And how does it kind of like tie in with the whole brain health thing?
Okay, I am
Absolutely.
grinning.
Yeah, I love
The
this
reason
question.
I'm
love
grinning
this
because
question.
this is one of the chapters that I sat back with a Diet Coke and watched Dr. Simmons and Dr. Mansbach debate it. So with that, Dr. Simmons, your stage.
Yeah, to me, I got several different definitions of delirium. I got to tell you though, my favorite one is the narcissistic one. The dementia I can't fix, the delirium I can. That's the first one. But you can then use time. I find diagnostically time never lies in a diagnosis. Dementia is usually a gradual progression, and it is implied to be permanent. With the exception of stroke, it should not be sudden. Delirium is sudden. Delirium, and I remember the example I used for delirium in the book was a patient in a nursing home I was caring for years ago, a brilliant man who I saw him one day and he was absolutely fine. I saw him the next day and he actually was missing his whole face with a sandwich and drooling and hitting himself in the eye. And I knew that it wasn't dementia because he had changed in a day. And I was able to identify, he had 2,000 milliliters of urine in his bladder. We put in a catheter and he could get the sandwich in his mouth the next day. So delirium is reversible. And as I went through that chapter of the book, it was quite mind-boggling how many conditions in the brain or in the body, that's a better way to put it, how many conditions in the body can cause delirium. I was speaking with Dr. Mansbach yesterday, and he's talking about getting me to give lectures on delirium to his nurse practitioners that do Jerry Psych. And as I explained it to him, you know, it's either above the neck or below the neck. And delirium usually, as an oversimplification, is when you're confused from something below the neck. It's like pneumonia, an infection, an electrolyte disturbance, a drug we gave you. Whereas dementia is quite simply above the neck. It's something in the brain. And there's exceptions to such a generalization, but that's I guess that's my final answer.
Great.
You know, and I think the second half of that was that the caregivers were asking, what do you do about it? Number one is make sure you see a doctor about it so that the doctor has a chance to try to reverse it.
And learn patterns. As I was doing house call medicine, I'm always educating my patients and my family members as well. You know, I expect a family member to be able to call me back and say he's doing it again.
Okay. Okay. Let's see. All right. Now this one, we're going down a rabbit hole here, but I know it's important. It says, in some of our previous discussions, there was a special advanced estate planning healthcare proxy or living will in the future where there are signs of brain health decline, memory loss or need for conservatorship or guardian. I think,
Yep.
you know, this is always an important topic because I know the three of us have talked to so many people that have had cognitive change, but didn't get that paperwork in place so that their
Yes.
loved ones can, if you want to elaborate on that.
Well, I will tell you, I thank whoever asked the question, and that's a ringer in the audience for us, I guess. I think people are sick of hearing me say, before you think something is wrong medically, get your legal and financial house in order, always. And that means not just your will. As I say to people, your will is what happens when you're dead. There's a lot that happens before you die. So you need your advance directives, which go lawyer to hospital administrator. That is not enough. So in Maryland, for example, there's something called the MOLST, the Medical Orders for Life-Sustaining Treatment. It's called POLST or POST in other states. You should look it up. There's actually an association, I think it's called post.org. So what you need to have in order are your legal and your financial documents giving somebody the power to care for you. Sometimes it says if you cannot take care of yourself, as in springing power of attorney. Other times it's actually enforced right away, as it should be if you're an older adult. You don't want to have to be declared incompetent before you have somebody else able to take care of you. So, for example, let's say you get hit by a bus and you end up at the hospital. The doctor needs to know what your wishes are. And Dr. Simmons, I hope you will clarify with the do not resuscitate versus do not intubate. But those aren't the only two things you need to talk about. Artificial hydration and nutrition. Will you have a blood transfusion? What are really your wishes? And then even more than that, who's allowed to make those decisions and who's allowed to make your financial decisions? So who's going to pay your mortgage or your rent while you're in the hospital? Who's going to sign your contracts for you to get into a rehab if you need to? Make sure that's all done. But Dr. Simmons, can you explain a little bit more? I get a lot of questions about DNR and DNI. What does it mean to resuscitate someone? When would you?
That's a discussion I have most every day. But as far as the I feel like I'm going to give two answers. I always remember doing a public access thing in Fairfax with an elder lawyer, and I'll never forget how she looked at the camera and she said, "For heaven's sake, call me before him, would you?" And
I say that all the
if you
time
get
too.
dementia
Yep.
on the record first and then try to sign papers, it's over at the beginning.
Yep.
So get your papers, then the doctor is first thing. Because once we write on paper that they have dementia, they can't sign and it becomes a whole nother thing. So
Yep.
that's the first thing. Now, do not resuscitate, do not intubate, having that conversation all the time, because at the nursing home level, you must have a MOLST completed or everything stops. And do not resuscitate. Okay, I always tell people, first of all, I'll say in a living will and an advance directive very rarely answers the questions on a MOLST. It's more interested in talking about not ending up a vegetable over a long period of time. Whereas the MOLST is curious about what to do in the first 3 seconds of a crisis.
Mhm.
Immediate. So if your heart stops beating, you're dead. That's the definition of sudden death. So are we going to resuscitate you or not? In other words, are we just going to do nothing? Or are we going to do something? Now, the something is everything. There's not much in the middle. So if your heart stops beating, you're dead. Do you want us to try to bring you back? Because we might crack ribs. You may or may not make it. And you just might come out with dementia that you didn't have or a stroke. We just don't know. But do you want us to do everything? As far as trying to recover you and stop you from being dead. In that process, it's called CPR, cardiopulmonary, compressions for cardio, breathing for pulmonary. That's where the word intubate comes in. You don't like go mouth to mouth anymore, I don't think. I think if you're learning BLS, they skip all the breathing. But, in hospitals, we do the breathing. We either use a bag mask, we try to get the air in, but we sometimes get a tube and we put it in the windpipe and we hook it up to a machine and we breathe for you. That's intubation. That's everything. That's the thing a lot of people don't want. So you have to clarify whether you want to be intubated. There is an ability. It's very hard if you're going to do compressions and have somebody try to fight you back from being dead. It's very hard to tell them to not intubate you. I mean, it's cardiopulmonary. So do not intubate means some people will say do CPR, but don't intubate me. I always feel like that's asking me to do it with one hand tied behind my back. It's not going to go well. And then again, the MOLST has all kinds of questions on it: antibiotics, testing, transfusions, dialysis, feeding tubes. All of these questions are there to inform emergency personnel. And just as a last closing remark, I have lost count of the number of times I have heard the paramedics come down the hall and ask where the MOLST is before anything else is said to them. The professionals about rescuing people and taking them back, that's the first words out of their mouth. Where's the MOLST? Where's the MOLST? Where's the MOLST?
Mm-hmm. Absolutely. And I did see in the chat, somebody pointed out a do not transport. That's actually part of the MOLST. And that is,
yeah,
do you want to be transported to the
Yep.
hospital or not transported to the hospital?
It's right below whether you
Okay.
want to be transfused or not. There's all kinds of questions. And
Oh,
you know
oh,
what?
absolutely.
When my little box runs dry, my little MOLSTs, I Google MOLST, Maryland PDF, and I print them again. So you guys could Google it too. Just Google MOLST.
Yeah, I put a few
Those are the
links in there.
questions. It's very easy to find. I do it once a
Perfect.
week.
Yeah.
And
Okay.
those are discussions you should have with your family
Yep.
and with your attorney before you ever get to the doctor who needs to sign them. But
Yep.
again, it's also, what does do everything mean? And the legal definition, the medical definition, and the ethical definition are not the same. Make sure you know what you're asking for.
Yeah. And a lot of people are probably on these discussions because you've got a loved one that has some kind of cognitive impairment. One of the things that you can do for yourself, your family, your children is get those documents put together now before you need.
Yes.
Okay. I love this question. It's anonymous, so I can't give credit to anybody there, but what are the main things older adults can do to facilitate good brain health as they age? That's a good one.
That's why we had Dr. Mansbach involved in the book.
Yeah.
Yep.
Because
That was his chapter.
I want to say that I felt like if I were the only one writing the book, I had no way to make it a good news book. Because I'm talking about the disease state, getting confused, what you can do about problems. Whereas Dr. Mansbach, I thought it gave me a chance to have the spouse or the child of my patient find a way to not get it themselves. And I know that Dr. Mansbach, if he was here, he would talk about enrich. He would talk about a lot of the topics that are in the book. The idea of exercising regularly, not smoking, routinely challenging his mind. And by the way, if you can always do the crossword puzzle in ink without thinking, that doesn't count as cognitively stimulating exercise. Right. He said it's got to challenge it. Go learn a new language. He's tough on you with this now.
He is very.
Yeah, he wants you to improve your mood, which means you might need an SSRI, and we all know what that means now. And then there's control high blood pressure and have a healthy weight. So he would talk about all of those things. And I got to tell you, it doesn't matter who you're reading, they're going to bring those things up. And it's another example of use it or lose it. If you don't use your brain, you will lose it. Yes. There are fascinating twin studies too that show like the unmarried twin gets dementia, but the married one doesn't, and things like that. You could call that improving mood or challenging yourself mentally. Take your pick, but it's interesting.
So bad. Yep. I did see on the chat there was something just prior to that question. They were asking about the MOLST and POLST forms, MOLST, POLST, and Steve, I know you posted them, links to them.
Yeah, no, definitely.
Yes. And
Okay.
I thank you. I saw you put in Dr. Mansbach's website, so everybody can go to the BCAT,
Yeah,
or you
it-
can go to enrichvisits.org.
it-
But as Dr. Simmons said, it's your brain's part of your body. You got to take care of it.
Yeah, I dropped that in there. And then I also dropped in, we've got a discussion with Dr. Mansbach coming up
Yes.
next month as well. So you
that'd
get
be
to meet all three of these folks if you hit that. Okay, let's see. Karen says, my mom, 85, and her sister, 75, both have increasing anxiety as they age. Neither want to take a prescription for it, but is it affecting the quality of their lives? My aunt is asking, why is this happening to her? What is changing in her brain? Man, I'm telling you, this community asks the best questions.
They absolutely do. And before we get to Dr. Simmons, I will tell you, when I hear questions like that, I always say, get thee to a doctor and be honest about it. The studies have shown that because of during COVID, with people being socially isolated, there are increased incidences of anxiety and depression. And sometimes that anxiety and depression is either mimicking or exacerbating dementia, but you've got to go to a doctor. And so here we have one on the screen, but I would say to them, go talk to Dr. Simmons or one of his colleagues.
Yeah, I would say sometimes anxiety is a symptom and not a diagnosis. Sometimes fever is a symptom and not a diagnosis. Like if a person has a fever, I'm looking for the infection. If they have a cough, I'm probably looking for pneumonia. If a person has anxiety, it's a very common presenting feature of depression. And there's a lot of different kinds of depression. One of the things I don't know if thing is the right word, but I'm on the lookout when I was doing house calls and even now, if there's a lot of anxiety and a person's aging, you can become very anxious and depressed over loss of your own abilities. In a way, you're grieving over the loss of yourself in a way. So anxiety to me can be a symptom of depression. So I try to not treat anxiety as anxiety. I try to get to the next level and treat that.
Okay, excellent. And yeah, I mean, the other thing is too, and we hear this a lot, is how do we get our loved ones to go get that diagnosis? Because there's so many times, and I think in that question you could sort of read between the lines that it's sort of like, I don't want to be diagnosed. I don't want to hear the bad news. It can be so challenging.
Or that's part of it. And also in certain demographics and certain age groups, there's still some sort of a social stigma attached to what's perceived to be a mental illness. These are the same people that if they broke their arm would go to the doctor. So basically, to the family caregivers, I would say you approach it the same way Dr. Simmons just said. It's not a be all and an end all in itself. It is a symptom of, and let's get you checked with a good physical exam to see what's going on.
All right. This is great. And I'm glancing. I can't believe that we're almost an hour. We got some questions. I got some hands raised that I'm going to call on. Remember, folks, this is recorded. So if you have to jump off, you can catch it later. Robert says, I'm 85 years old. My health in general is excellent. I need help with balance and walking. I've not had any relevant medical events. I've tried several balance exercises without any improvement. What do you suggest?
That's okay. I would suggest first that if you were in my office and I saw that, like I don't know if they have clipboards anymore, but I saw that on the clipboard and I'm about to go in, and I saw the age that you had said, I would wonder if the person had something called, I hate to say it, but multisensory disequilibrium of the elderly is a term I've heard. But let's get away from the term. It's the concept that as you age, you lose a combination of so many little things that they add up to imbalance. Unfortunately, there's a lot of things that could diminish. It could even be as strange as perhaps your inner ear, your balance organ, is no longer able to process input correctly, and it gets loses coordination with the eye movements. I mean, it could be that a B12 deficiency is making it where you're not able to feel where your feet are the same. There's so many things that could lead into it. And it is one of those problems that we run into as we succeed in living to older age. So it's a workup for me that if I'm to get to the bottom of it, panel of tests, do an exam, let the exam, a neurologic one, lead you to something specific if it's found on exam, and then try to focus on whatever is underlying. But balance, walking, imbalance can be very challenging. That's why if you're looking for a referral to the best type of it would be neurology, to the best kind of a referral, I would say don't just go find a neurologist. Go to a movement disorder clinic within a neurology department. You see, if it wasn't so unique, why would they have a whole department that's different? And Georgetown Neurology has a satellite office in Olney just for movement. So movement disorders are unique and so specific and individualized that Georgetown Neurology, a mecca of nerve disorder, has a whole clinic just for it.
Yeah, Robert, really good advice from Dr. Simmons there. Also drop in the ANOVA Movement Disorders Center.
Yep. Yes.
It's amazing what they are doing now. And it's not just Parkinson's disease. There are a variety of things. But the other thing too is that there's some great classes and things of that nature that people with movement disorders, you know, if you don't use it, you lose it and all that.
Exactly.
Okay. I love this question here. It's when I turned 65, 20 years ago, I asked my Kaiser Permanente physician to recommend a geriatrician. His response was, most of my patients are over 65. I searched the website and determined that KP did not have any geriatricians. And again, this was 20 years ago. But she thinks it's still true today. At 85, I feel my need for a geriatrician is greater. And she'd love your all's perspective on that. And how do you find that quote unquote geriatrician? Because I can see a lot of doctors saying, hey, yeah, I've grown old with my practice. I'm basically taking care of older adults.
So one of the easiest things to do is look at the American Geriatric Society. There are a lot of doctors at this point, and Dr. Simmons, I hope you'll elaborate on this, but there are a lot of doctors who did not get board certified in geriatrics, but as they aged and their patients aged, they continued their education in geriatrics. So they may not use the word geriatrician, but they are at least involved with the societies, the education, the patient base, etc. But can you elaborate, Dr. Simmons?
Yeah, I could certainly elaborate because I'm not a geriatrician. I have the unique position. I believe I'm the only non-geriatrician in my geriatrics department. And I was brought on, I believe, based on the experience I had in doing house calls for more than a decade and then working in assisted living for so long, and a focus on geriatrics. I've even been a member of the Geriatric Society for several years. However, I always remember the first geriatrician I watched get board certified, and it was a family practitioner in rural Tennessee who passed his test the third time's charm, right? So he was a geriatrician. No training, just take a test. Now you have to do a fellowship. So what you would do is you would become what I am and have been for years now, an internal medicine board certified physician. Then you could do a geriatrics fellowship for several more years, usually 3, and pass your board exam and you're a board certified geriatrician. Okay, that's how you become one. Now, Where you can find one, difficult, not a lot in the country. I know quite a few in my department, I gotta admit though. I know that up here in Maryland, I know that our department has based at the hospital at MMMC, we have a Center for Successful Aging, where we have a multidisciplinary approach that's headed by a geriatrician, Dr. Razan Khalil. She's excellent. And I know that there's other options around. But I think you go to the Geriatric Society, you can Google, we all Google. I could certainly put you in touch with an incredibly good clinic close to where I'm sitting now at MedStar Montgomery Center for Successful Aging. But it's just you could talk to your primary care doctor, say, do you know someone? But unfortunately, it's a very limited resource.
Yeah.
Exactly. Also, major academic medical centers that have hospitals affiliated with them will usually have a geriatrician if you really want the board certified geriatrician. But again, what you really need is somebody who has experience in dealing with the issues surrounding older adults.
And okay, Dr. Simmons, both of you have a growing fan club, but a few questions. How can somebody are you practicing privately? Can you take on private residents, or do we have to move to Brook Grove Foundation to become your...
For me right now, my practice focus is here at Brook Grove, working in the rehab center and taking care of some long-term patients in both the assisted living community here and in our long-term nursing center. That's my current practice focus. So that would be the only way to see me at this time.
Okay, great. Well, I put the link to Brook Grove in there and
move in, I guess, right?
We'll go check it out. Okay, and we're getting close to an hour here. Bunch of people are saying this is such a great discussion. They want you all back, and they're ordering the book. Robert is ordering the book right now. And let's see, I want to try to get this. Yeah, I'm going to throw Brook Grove in again there. For the person that asked that question. It's a life plan community in Olney, Maryland, in Montgomery County on hundreds of acres. It's actually a pretty impressive campus there. Okay, let's see where we at here. The docs in hospitals ER's first inclination is to save the person in front of them. I had a doctor say advanced medical directives was unclear.
Yes.
It puts a lot of pressure on the person making the decision. Is to do better to help the docs, not necessarily try to save the person, but truly follow the advanced directive.
That's why you use a MOLST form and don't worry about the advanced directive. And I have literally been with Dr. Simmons where he's calling the ambulance on a patient and I am taping the MOLST form to the patient's chest as we're waiting for the ambulance.
Wow.
So you make sure that the MOLST form is completed. The ER will read the MOLST form. They will not read the advanced directive. Those are not medical orders. An advanced directive is a legal document for lawyers and the hospital administrators. It is the actual pull the plug permission, not the prevent the plug from going in.
Hey, very well stated. Okay, what steps, medicines, activities, therapies to take addresses losses for a mid-50s person with MS who's having challenges with short-term memory? A psychological evaluation noted challenges with short-term memory. Are there any tests to determine specific brain issues? And I guess the BCAT and but yeah, probably a neurologist, or what are your thoughts on that?
I always say go to the easiest
I would think
answer
a
first.
Neurologist, it's hard. If you have, well, look, if you have multiple sclerosis, you have a neurologist. That doesn't mean they're great at dementia care. So I would ask them, is this something you're comfortable with, or can you send me somewhere, or do you have somebody in mind? Because again, if there's a movement disorder clinic, there's a memory impairment clinic as well. So a lot of neurologists do focus on it. Now, most of our capacity testing, in the simplest version is who's the president, the hardest is like you spend all day doing the neuropsych eval and a 15-page report shows up a month later. I mean, that's the end. And there's a lot of testing in the middle, but all of it does is it just measures the degree of your decline, how bad it is, how good it is, where the specific deficiencies lie. If you're looking at the point of view, I'm mid-age, I got MS, I'm starting to have problems thinking. My suggestion would be make sure that you're taking care of everything below the neck to observation. Follow up with your primary care doctor, make sure you're taking your meds, getting your labs. Then I would say, if unfortunately there is some kind of a mental decline, capacity testing, anything from a mini mental status on up could help to detect that. And if it is detectable, I would then seek the help of a neurologist that's proficient in memory impairment.
Excellent. Okay.
Steve, I saw on the chat, there's a little confusion about when to use the MULST and the PULST, and somebody did see, they read correctly that it's supposed to be end of life. That is because that is the political scenario in which it had to be phrased to function. That is not the practical way it needs to function. So yes, you are reading it correctly to the person who sent that in the chat, but it is not necessarily true. You want to make your wishes known whenever it is you want to make those wishes known, and then you reevaluate that over the years.
Okay.
I know that if I want my phone to ring tonight when I go home, all I got to do is not do a MULST on a new admission.
Oh,
My
well,
phone's ringing.
wow, that's really
I know that.
that's really telling and impressive that we've got policy that is making an impact like that.
The state pays attention in Maryland big time.
Excellent.
And Virginia's slightly different, and there's, I think, 37 states, and we have 37 different 37 different answers, but it's the same general concept.
And Arlene says, 20 years ago, my estate planning attorney said no MULST. Now she says do a MULST. So it's a clear policy change, that's for sure.
Yes.
Okay. All right. I think what I'm going to do, there's one question here, and because we're already over an hour and we've got 2 giveaways of the books and all that stuff. Let's do this one, and then we're definitely going to have you both back on. Can you talk about brain health and hydration and dehydration, intravenous use of providing nutrients, hydration, and vitamins? Our family friend's 96-year-old mother says she does not like and refuses to drink water. So the family feeds her a lot of watermelons, fruits, vegetables like peaches, cucumbers, and strawberries. Should determination need to be made about hydration and dehydration, and how her general well-being and health and brain health are affected by these? Man, so many great questions today, I'm telling you. And one of the sponsors does that intravenous hydration. So your thoughts on hydration and brain health and all that stuff?
I would be surprised if I reread that chapter I wrote 5 years ago and there's not some comment on dehydration in the delirium section. Certainly, one of the most common orders I gave in Kaiser when I was working in urgent care, and I was there 20 years ago, when I was there working in urgent care, was to start an IV, send labs, give some fluids. And it's amazing how often you could come into a confused patient's room and you return after IV hydration and they're not confused anymore. We are 60% water, roughly. Water is absolutely necessary. And in fact, it's a major component of blood, and your pressure will drop without it. So what's the role and how do you utilize that? I know how to utilize it in an emergency room, an urgent care center, in my nursing home. I've even a couple of times arranged it in the home, but I'm not sure about the clinic that one of your sponsors had, which is a very intriguing idea.
And the other thing is, It is not at all unusual for older adults, particularly people with dementia, to not want to drink water or things like that. Popsicles work.
Yeah, but
Flavored. Yep, go ahead.
but also you have medical problems that make it very difficult to swallow. I mean,
Yeah.
we talked about stroke. Stroke brings swallowing issues.
Sure.
I've lost count of the number of times that I'm like, oh, thrush, huh? Look at that.
That's true. Yeah. Yep.
So look in the mouth, look for dental problems, look for swallowing issues, make sure you're not missing a thrush. And if you see it really bad in the mouth and you've missed it for a long time, it's in the esophagus too.
Man. All right. Well, this has been awesome. I dropped Jodi's info into the into chat so you can get in touch with her. But I want to share that if you visit CareBrains and you there's Jodi's email, which is in chat. But if you use the code JODI 10, you get 10% off on training. And do you want to talk a little bit about that? What does that training entail?
Oh, sure. Thanks, Steve. So we have 2 different kinds of training. Well, actually 3 different kinds. We have the medical training for professionals where you get CME, CEU. It's all ACCME accredited. We have training for the attorneys, which is also accredited. And then we have family caregiver training. What's different about our family caregiver training is it's based on exactly what we're teaching the doctors and lawyers, so that people who are family caregivers can actually help their professionals understand what their needs are, so that everybody's really on the same page. And again, because we added this code because you're on this call, because of our Steve Gurney and our friends, you get 10% off of the training. Make sure to add the code JODI10. And also, if you have other questions, you can indeed email me at carebrains@clickmedics.com. ClickMedics is the tool that powers our CareBrains, and I'll be sure to get them to Dr. Simmons as well.
I love it. All right. Okay, so with that, let's welcome any CarePatrol team members that might still be on stage there with us. And all right, we got Marjorie and and then we're gonna spin the wheel of names again for 2 more books. But before I do that, CarePatrol team, thanks so much for getting these folks. It's been a great discussion.
I have no words. I thought it was just a fantastic presentation, and we're so grateful to everybody and our speakers and our, of course, our moderator and our sponsors and everybody that attended. Thank you so much.
I love it. All right, so let's get to spinning here. And all right, so who is our first book winner? And Mariette Young, she won the gift card earlier. Okay, so we got Ron Ossie gets one of the books. So we will send an email to Ron and get his address. And then let's see who the final book is. And then we will move into 4th of July holiday. Cindy Burford. Okay, and I've written those down. I will get those emails out, and we can make sure to get those prizes to our winners. But any closing thoughts for anybody that's on the screen right now? We're good? All right. Okay, folks. Well, have a great long weekend, holiday week. And I am going to get the recording up this afternoon, and we'll see you all at the next CarePatrol discussion. Thanks so much.
Perfect. Thank you.
Thank
Bye.
you, guys. I appreciate you
Bye.
setting it up. Thank you. It's fun.
You bet.